Oh, no audio. Oh, let's see if this works. I think it should be on. Thank you for that. Oh, okay. All right, good. Good. How have you been? How's your day going? I'm trying to see if I can stream it on YouTube in the meantime. Rough. Oh my word, I'm sorry to hear. I am so sorry to hear. It has been good. It was a little bit long. I never really saw much patient, but for some strange reason, it just feels like it was one of those long days, very long days. I don't know if probably because of where the patients were. Yeah. They were like 15, 20 minutes driving between. And I was like, no, I'm not used to driving this long between patients. So I kind of feel like, it was a wasted day. Just to see 5 patients. Well, one of them was in the hospital, so I didn't see that one. So, some questions. Yeah. And answers. All right, let me go ahead and put this up here. Remember to go ahead and follow me on YouTube as well at ThinkNursing. Oh, thank you for that. Luminous, how are you doing? Welcome. I saw your message. I said, girl, I was so tired and exhausted today. Like, yeah. When I got home, I just get a bath and just head straight to bed. Yeah, Safia, welcome. How are you doing? Yeah, man, but definitely, so tomorrow I have 4 patients. We can chat anytime. You can WhatsApp me or anything as well. All right. How are you, Safia? Thank you for the heart, Mies. Yeah. Let me just put on a little filter on this thing here. Because this morning somebody on YT was like, yeah, turn off the filter. Not this morning. It was this morning. I think it was last night. Right, this morning. Turn off the filter. No much troublemaker, you know. Yeah, you have a lot of troublemakers who come online. It was like, turn off the filter. Someone turn off the filter. I say, oh, okay. Yes, okay, nice. TS Music, welcome. Thank you for the rules. How are you doing? Unbroken, how are you doing? Good evening to you too. Ready for session? Ready for class? I'm gonna tell you a joke when I have my tablet. Yeah. So how are you? Okay. So we don't need a filter. We still need a little video to look good. You know them way there? Yeah. Because I'm sure if the filter not on, probably 3/4 I won't click on it. You ready? Alright, good. So how your work went today? Unbroken. Hi, TS Music. Welcome. How are you doing? Thank you so much for tuning in. Alright. Thank you so much for tuning in. David Dale, welcome. Renorta, welcome. Thank you for liking up the live. And remember to go ahead and share the live. Yeah. And remember to tap up the screen, all the wonderful things that you normally do on a regular page. You understand? All right, get the video or get the video out on the YT page as well as other persons to come online. Okay, nice. How I'm doing? I'm doing good. My day went well. Couldn't have been any, better. It has been good. Yeah. Or it could have been better, but I'm not complain. I'm not gonna complain. Your work went well. Okay, yeah. Mine too. Watchman up on the wall of Zion, up and running. Yes, as usual. Let me see if I can get the questions over here. As usual. Chat. So we're gonna do 1 hour today because I'm trying to control the time. All right, so control my time on the internet here, because I realize most of the time I'm like chatting away. All right, so we're gonna do 1 hour today. On Thursday we can do a few hours because on Fridays I'm not working, but tomorrow I'm working, so I wanna make sure that I am not going too much on the time during the week. Thank you for liking up the live. What's your thoughts on the shooting that has been going on in Utah? Unbroken. Oh yeah, I can mix me up for now. Seminary, they see the news like that yet. Oh, that's the one with Charlie Kirky talking. Is it the one with Charlie Kirky talking? A little busy, so sometimes might not be answering, but I'm still listening. You're good. I'm a nursing school, starting nursing school January. What do you recommend to start reading? You can start your fundamentals of nursing textbook. The course boring, but there's so many things you need to learn from that book. So start with that book, RIM 654. All right, as well as Intro to Profession of Nursing. I'll say start reading on those. Yeah. Hi, Marvin. Welcome. Yes, I'm doing good. How about you? Yeah, I am doing good. Thank you. All right. So we're going to do some questions tonight. And then from there, as usual, keep the questions coming. Okay, nice. Keep the questions coming and, just answer A, B, C, D. If you're not so sure, just think of it. You're at the patient's bedside and you're trying to save this patient life. You have to choose an answer. You have to do something. All right, that's how we're going to do it. And then from there, we can always just discuss the question as well. All right, I guess I'm going to have to use my phone here. All right, so Taurus Jules, welcome. All right, so let's go. I'm gonna try to see if we can do at least about 100 question. I don't think we'll be able to complete so much, but we'll try as best as possible. All right, so, and if you have any questions that you want me to probably prepare, it's like cardiovascular, gerontology, not geriatrics, anything like that, then definitely go ahead. And you can always post it and I'll prep some questions so you can come and just sit down and discuss them. All right. Thank you for liking up the live. President Fight Against Abuse. All right, let's go. All right, so this one, I need my... All right, so a nurse is caring for a client with heart failure who is prescribed furosemide. Which finding indicates the medication is effective? And this is an easy question. Is it A, blood pressure 150/90, weight loss of 2 pounds in 24 hours, C, presence of bilateral crackles in the lungs, or D, pitting edema in lower extremities? I tend to find that we're getting a lot of questions regarding the furosemide, the loop diuretics here. All right, so a nurse is caring for a client with heart failure who is prescribed furosemide. Which finding indicates the medication is effective? Is it the blood pressure of 150/90? Is it the weight loss of 2 pounds in 24 hours? Presence of bilateral crackles in the lungs, or pitting edema in the lower extremities? And if you know what loop that, well, not loop that, I'm not going to say it, but if you know what furosemide does, then you'll be able to answer. So B, do we have anybody else that have any other answer to that? What about on YT here? All right, so we're going to go, it's B, weight loss of 2 pounds in 24 hours. Why you choose that answer, RIM 654? put you, I'm gonna add you as a guest. Or what medication is furosemide or Lasix? What class of drug is it? All right, so it's a loop diuretic, and the mere fact that the patient has lost weight, it means that the medication is actually doing its job. It's actually pulling that fluid, so the patient is gonna lose that fluid, gonna be weighing less. All right, so that's why you have the daily weights when you're working as inpatient. You notice that they do daily weights on the patients to make sure that it is pulling, reducing that fluid in the patient. Good. All right. Blood pressure 150/90. It hasn't really done anything for that blood pressure. Presence of bilateral crackles in the lungs, still not effective. All right. You want to make sure you're pulling, getting rid of that fluids there. And bilateral edema in the lower extremities, basically the medication not working. All right. So furosemide is a loop diuretic that reduces fluid overload. A 2-pound weight loss in 24 hours is effective in terms of diuresis. Crackles and edema indicate fluid retention, and elevated blood pressure shows that the medication hasn't been fully effective. All right. The nurse is providing teaching to a client with type 1 diabetes who is starting on insulin therapy. Which statement by the client requires further teaching? Is it A, I will rotate my injection sites to prevent lipodystrophy? B, if I'm sick and not eating, I'll skip my insulin dose? C, I'll check my blood sugar before meals and at bedtime? D, I'll keep some fast-acting glucose with me in case of low blood sugar. All right, so Renorta says B. Okay, do we have anybody else? So a nurse is providing teaching to a client with type 1 diabetes who is starting on insulin therapy. Which statement by the nurse or the client requires further teaching? I will rotate my injection sites to prevent lipodystrophy. If I am sick and not eating, I'll skip my insulin dose. I will check my blood sugar before meals and at bedtime. Or D, I'll keep some fast-acting glucose with me in case of low blood sugar. Hi, Ali Edits. Welcome. Do we have anybody else with an answer? All right, so the answer is actually B. All right, if the patient says that if I'm sick and not eating, I'll skip my insulin dose. All right, you know that that patient didn't get the message. They don't understand. So definitely you never skip your insulin dose, even when you're sick. So the insulin needs may actually increase during illness due to stress response. And when you rotate your sites, you actually prevent your lipodystrophy, which is basically the breakdown in the fat there. Because you don't want it to be a case where you constantly be injecting the same sites. It's always encouraged that you rotate. All right, so locate your different sites. You can actually do your subcutaneous injections. And from there, you just rotate them. Left, upper, you can do thighs, belly. The belly is big enough. We have a lot of belly fat there. So utilize all of that. All right, and encourage a patient to do that. And also carry glucose. Carrying glucose are correct practices. All right. A client with a COPD is receiving oxygen at 4 liters via nasal cannula. The nurse notices the client becomes drowsy and less responsive. What is the priority action for this patient? All right, so the patient is a COPD. The patient is on 4 liters of oxygen, and the nurse notices that the patient is drowsy and less responsive. What is the priority action here? Is it to increase the oxygen to 6 liters per minute, stop the oxygen immediately, assess the respiratory rate and oxygen saturation, or call the healthcare provider right away? What would you do? You're at this patient's bedside and you realize that the oxygen level is, the patient is sleepy. All right, the patient is on 4 liters of oxygen via nasal cannula, and the patient is not responding as usual. What would you do at that time? Call the healthcare provider right away. Renorta says, do we have anybody else? Rim says C, assess respiratory rate and oxygen saturation. Okay, nice. Definitely you want to go ahead and assess your patient. You're always going to call the provider, you know, but make sure you go ahead and assess your patient. That's the first thing you're going to be doing. You don't want to be a case where it's something that you can actually deal with. You know, you can resolve it at that time. And you go ahead and call the provider and waste basically your time, the provider's time. And not only that, you know, the patient is there. What can you do at that time to make sure that the patient survive? All right, it might sound simple, but what can you do at that time? What is your first nursing action? All right, you try to do that and then you run and go call the doctor. All right, so Luminous says C. So assess the respiratory rate and oxygen saturation at that time. That is going to be your priority, you know, action. You want to make sure that the oxygen saturation is where it's supposed to be. You check the patient respiratory rate and it is within normal, you know, limits, whatever it is. And then from there, you can always go ahead and let your provider know. All right. Or activate the necessary protocols, whether or not you're going to call rapid response or whatever it is to get persons to the bedside for this patient. All right. So the clients with COPD can develop CO2 narcosis when given too much oxygen. The nurse must first assess the client's airway and breathing before intervening further or calling the provider. Increasing oxygen could worsen the problem. Stopping the oxygen abruptly can cause hypoxemia. All right, so you want to make sure that you assess your patient and then from there, you go ahead and, you know, speak with your provider. All right. Oh, we're doing nursing questions here. All right, so if you're a nurse or even if you're not, still go ahead and participate. Share the live with somebody or the page with somebody. All right. All right. So the nurse prepares to insert a urinary catheter. Which action should the nurse take first? And remember to go ahead and like up the live, all right? I might forget all of those things, but we're getting questions done, all right? The nurse prepares to insert a urinary catheter. Which action should the nurse take first? Is it to put on the sterile gloves, position the client, open the catheter kit, lubricate the catheter kit tip? All right, so clean the area first. Definitely you want to clean the area first, but remember, you're going to be working with the answers that is presented on the test. All right, so the nurse prepares to insert a urinary catheter. Which action should the nurse take first? Is it to put on the sterile gloves, position the client, open the catheter kit, lubricate the catheter tip? Put on sterile gloves. Okay, so Renorta says put on the sterilized glove. Do we have anybody else with any answer? And when you're answering the question, try to just close your eyes and think about the procedure. All right, what is it? The step-by-step that you're going to be using to do this procedure. So Rim says D, lubricate the catheter tip. All right, so the answer is actually B. Rotate the patient first. Okay, so position your patient. All right, doesn't make sense you put on your sterile glove and your patient leg close up. You understand the kit is already still closed. So just think about the process. How you're gonna go about with doing this. You position the patient, keep the legs flexed, you know, legs open. You go ahead, you open up the kit. Different, you know, depending on how you're gonna be doing it. Because if you don't have assistance, you're gonna probably do all of that first. All right, and then from there, so just think about the step. You want to go ahead and open, but then you don't want to open it for the entire time, and then you're having problems with positioning the patient. So if you're able to position your patient, then you go ahead, open your kit, you know, and then after, the last thing you'll do is put on your sterile gloves, because at that time you would have prepared everything. You'll be going in your kit, your sterile field at that time, so you don't want to contaminate your gloves and everything. And then you decide which one is a dirty hand and which one is a clean hand. And then from there, you go ahead, lubricate and insert. Fire, what's up? Thank you for tuning in. All right. Yes, so definitely that's what you have to do. Just close your eyes and just think about the procedure that you'll be doing. And then from there, hopefully it will be a little bit easier for you to answer the question. All right, so the answer is B. The first step is to position the client properly. Sterile technique follows after positioning. All right, because remember, once you position the patient, you're not going to touch the patient again with your hands because you're sterile. All right. A nurse is caring for a client with restraints. Which action requires immediate intervention? Removing the restraints every 2 hours, using a quick release knot to tie the restraint, attaching the restraint to the bed, the side rails, and documenting the client's behavior. So a nurse is caring for a client with restraints. Which action requires immediate intervention? Is it removing the restraints every 2 hours, using a quick release knot to tie the restraint, attaching the restraint to the bed, the side of the bed rail, or documenting the client's behavior? So which action requires immediate action? Releasing the restraint every 2 hours. Do we have anybody else with anything else? Renorta says that. So is it removing the restraints every 2 hours, using a quick release knot to tie the restraint, attaching the restraint to the bedside rail, or documenting the client's behavior? A, B, C, or D? Someone on YT, you're saving this patient here at the bedside. What would you do? Just choose an answer. All right, it's better to do something than to not do anything. Fire says A, which is remove the restraints every 2 hours. Do we have anybody else on YT? And thank you so much for tuning in if you're not a nurse. Oh, I don't really understand the language there. Sorry. But I figure more or less you're saying hello. All right. So the answer is actually C. All right. It says restraints must be secured to a non-movable part of the bed frame, not the side rails, to prevent injury. All right, so the question reads, a nurse is caring for a client with restraints. Which action requires immediate intervention? Removing the restraints every 2 hours. So usually you'll go ahead and you'll renew your restraints depending on, the age of the patient. If it is every 2 hours, 4 hours, depending on it. All right, and you remove the restraints and do your assessment at that time. So you wouldn't need to do like, run to that patient first, or that doesn't really require immediate action. Using a quick release knot to tie the restraints, that's appropriate. All right. You always want to be a case where if in the case of an emergency, this patient is coding or you have an earthquake going on, you want it to be a case where one pull, you release the patient with that one tie knot. All right. Documenting the client's behavior. You always have to have some documentation as to why this patient is in a restraint. So document how the patient is, and then from there, that is a part of your assessment. So you can't just say you have a patient in restraint and you don't have anything to back up why you put a patient in restraints. All right. So that is good. But attaching the restraint to the bedside, the bedside rail is inappropriate. You always want to put it on somewhere on the bed that is movable. All right. And not on the bed frame itself. So that's the one that you'll definitely need to address. All right. So which client should the nurse see first? So you have 4 patients here. So you're going for your shift and you see, you get your report and these are the 4 patients you have. Which one would you run to first? A client reporting pain of 7 out of 10. A client with a fever of 100.9, which is 38.7 or 38.3 degrees Celsius. A client with an oxygen saturation of 86%. A client asking about discharge teaching. Which one of these patients would you run to first? If you get a report with these patients, who would you see first? A, B, C, D. A patient reporting pain 7 out of 10. A client with a fever of 100.9. A client with an oxygen saturation of 86%. And a client with who is awaiting discharge teaching. So those are your 4 patients. You go in and you just got the report. Who would you go to see? A, Renorta says A, the client reporting a pain of 7 out of 10. Do we have anybody else battling for that? Rim says C, a client with oxygen saturation of 86%. All right, so definitely C is going to be the answer. Please say letter when you're reading the options, please. Not a problem, Fire. I will definitely do that. All right. So C, the client with oxygen saturation of 86% is the one that you're definitely going to be running to first. All right. Because always think about, your ABCs. All right. Always think about your airway, breathing, circulation when you're answering your questions. Always use assessment to answer your question as well. All right. So the client with the oxygen saturation of 86% is experiencing hypoxia. The oxygen level is too low. So you want to definitely go ahead and address that before, the patient starts becoming confused or having other problems because of that. All right. A client reporting pain out of 7 out of 10. They're in pain, and 7 out of 10 is what we consider to be severe pain. You definitely want to address that patient, but I've not really seen where pain kill anybody yet. So, that patient can hold off a little bit until you address the patient who needs, oxygen. All right. A client with fever of 100.9 definitely needs to be addressed as well, but can still wait. And the client asking for discharge teaching is always going to be the last one to leave the room. All right. So address all the others and then the discharge teaching afterwards. All right. A nurse notices that a new nurse is preparing to recap a used needle. What is the appropriate response? So you are the nurse or that is there, and you see someone recapping. It's a new nurse recapping the needle after she had just given the injection. All right. What would you say to that person? A, assist with recapping safely. B, report the nurse to the supervisor. C, remind the nurse to discard the needle in sharps container. Or D, ignore it because the nurse is new. So you realize that the nurse is, a new nurse is preparing to recap a needle, a used needle. What is the appropriate response? So we have CC there. Okay. So yes, you remind the nurse to discard the needle in a sharps container. Never recap your needles. And even if it is not, used, you haven't used it on any patient, don't practice to do that. Because even so, needle stick injury, whether or not it is from a used needle, you don't want it. So never recap your needles. Always go ahead and discard it in the sharps container. All right. So needles should never be recapped. They must be discarded immediately into a sharps container. All right. Hi, Marvia. Welcome. Assist with recapping safely. That's a no-no. Report the nurse to the supervisor. You're kind of taking it too far. You understand? No. You don't need to report that to the supervisor. And even if the nurse had, well, at least that's for me. Even if I see that she had recapped it and, she safely did it, that is something that I wouldn't even report to the supervisor. You just talk to the person as a colleague, as your own colleague, and then from there. If you realize it's a continuous, practice where that same one nurse is recapping, and even though you talk to her as your own colleague, then you can always probably talk to your supervisor and say, hey, probably this person needs to, be reminded because you've seen it multiple times. But usually if you don't have to jump to your supervisor, don't be that quick to do so. All right. And ignore it because the nurse is new. No, never ignore it. We're never too, old to learn. And even if the nurse is new, don't ignore it because she might not know any better. All right. So always just go ahead discreetly, say to her, this is what the situation is. So, she prevents that from happening next time. All right. The nurse is caring for 4 clients. Which client requires isolation precautions? Is it the client with tuberculosis, A, B, a client with diabetes mellitus, a client with congestive heart failure, C, or D, a client with appendicitis? So you have these 4 clients. Which one requires you to have isolation precautions? Okay, tuberculosis, A, yes. And what precautions would you use for your tuberculosis patients? Fire says A. Welcome. What precautions would you use for your tuberculosis TB patients? Droplet, separate. Which one you separate now? PPE. Okay, so yes, so you're gonna be using PPEs, but what PPEs are gonna be covered under what is it that you're gonna be using in terms of PPEs? So we're gonna be using the airborne precautions. So you're definitely going to get your N95. You don't walk in looking like, the cute nurse without your mask. All right. You definitely want to be wearing your N95. You get those patients in your negative pressure rooms. All right. And, just limit the amount of persons that are going in there because of the risk for exposure. All right. So your face mask, gown, gloves, well, not just the face mask, but it has to be the N95. If you're not saying the N95, you're going to get the TB from that patient, all right, because it's an airborne disease, all right? So TB requires airborne precautions, N95 mask, and a negative pressure room, all right? So, all right. Question. Okay, no problem, Luminous. While she's preparing her question, just for me. Huh? All right. So a client is taking lithium. All right. A client is taking lithium, reports nausea and tremors. Which action should the nurse take? Document the finding as a normal side effect. Encourage the client to increase sodium intake. Notify the provider immediately, or withhold the medication and monitor for toxicity. So you have a patient that is taking lithium. So you have a psych patient that is on lithium. And you notice that the patient is having tremors. The patient is also nauseous. Which action should the nurse take? Would you document the finding as a normal side effect? Is it B, encourage the increase in sodium intake? C, notify the provider immediately? Or D, withhold the medication and monitor for toxicity? I wanted just to say the question previous. Oh, you wanted me to repeat the question? Oh, sorry. So let's just go back a little bit. So the question was, the nurse is caring for 4 clients. Which client requires isolation precautions? Is it the client with tuberculosis A, B, the client with diabetes mellitus, C, the client with congested heart failure, or D, the client with appendicitis? So which of those patients requires isolation precautions? It didn't say specifically what kind of precaution, like, if it is airborne, droplet, contact. It's just general. So which of these 4 patients requires you to put on some, extra PPEs? And that would have been the patient with the tuberculosis. I hope that answered the question, Luminous. All right. So the client with the lithium, I know she said she was busy. The client with lithium reports nausea and tremors. Which action should the nurse take? Is it A, to document the finding as a normal side effect? B, encourage the increased use of sodium intake? C, to notify the provider immediately? Or D, withhold the medication and monitor for toxicity? So which one? A, B, C, or D? So you have a patient that is on lithium and starts reporting nausea and tremors. What are you going to be doing? Document the finding as normal, encourage sodium intake, notify the provider, and withhold the medication and monitor for toxicity. Maybe I'm guessing A. Okay. All right. C, Holy File says C. Do we have anybody else? And Marvis says A. All right. So the answer is actually D. All right. The one that says withhold the medication and monitor for toxicity. And if you realize, a lot of times you're doing the questions, nausea, nausea, headache, anything like that. Yes. Nausea, headache, tremors. When you see any question that is talking about toxicity, most of the time the answer is the one with the nausea. You always want to withhold the medication. All right. So with lithium, let's just read on that. Lithium toxicity occurs when the amount of drug in the body exceeds the therapeutic level, which can result from an overdose or a gradual buildup of the medication. Since lithium has a narrow therapeutic index, even slight increases can lead to dangerous levels. The symptoms can range from mild GI issues to severe neurological problems, coma, or death. All right, so definitely if you see any changes like those, then you want to go ahead and withhold the medication and get your levels. So if it's a case, you're going to go ahead and do a blood draw to look at their lithium level to make sure that it's not the medication that is too much in the body. All right, then you can always go ahead and do that to check on the levels before continuing that medication. All right, nausea is a side effect. Yeah, and nausea is a side effect for almost every medication. You understand? You look at the back and you might hear or you read on it that the nausea is, but because of the narrow, the narrow index, the therapeutic index can be a little bit narrow for lithium. You have to be very, very careful. You don't want it to be a case where even though probably nausea might not be related to it, because you probably do the lithium level and it is normal. All right. But you just don't want to run the risk of having this patient experience toxicity because of the lithium. All right, so you definitely want to go ahead and withhold the medication, and then from there you monitor the patient. The tremor is serious. Yes, definitely the tremors are very serious. All right. And some other things that can cause lithium toxicity as well is like dehydration, changes in the diet. You might have interactions with other drugs, overdose, or kidney problems. All right, so all of those are things that can contribute to that. So the nurse is preparing to administer IV vancomycin. Yes, coach, resilient kidney issues, definitely. All right, so the nurse is preparing to administer IV vancomycin. Which finding would make the nurse hold the medication? Is it the BUN of 18 milligrams per deciliters, white blood cell count of 11,000, C, the creatinine of 2.5 milligrams per deciliter, or D, a temperature of 100.8 degrees Fahrenheit? All right. So the nurse is preparing to administer IV vancomycin. Which finding would make the nurse hold the medication? Is it the BUN of 18 milligrams per deciliters, a white blood cell count of 11,000, the creatinine of 2.5, or the temperature of 100.8? A, B, C, D. Sorry. A is the BUN of 18. B is the white blood cell count of 11,000. C is the creatinine of 2.5. And D is the temperature of 100.8. All right, so with this, you have to, based on the numbers here, you have to know your normal values for your labs. All right, so you have to know your normal values for your labs in order to answer this. So is BUN of 18, is that normal or abnormal? And depending on, different companies, they will have their own, set of normal values. All right. So the normal range can be anywhere between 6 to 20 milligrams per deciliters. And it's always going to be dependent on the age, the gender, all of those. All right. So the 18 is normal. White blood cell count of 11,000, is that normal or abnormal? So that is normal because you want it to be, it's abnormal. So 5,000 to 10,000 is what you're looking for in terms of your white blood cell count. All right. And as I say, it depends on, the company, or depending on, I have my labs tomorrow for manual and this, I don't need to fast Wednesday. Okay. Okay. The creatinine 2.5 milligrams, is that high or low? And then the temperature of 100.8, that is high. All right, but the creatinine here, if you know that what vancomycin does, so vancomycin tend to affect the kidneys. So you always want to make sure that your creatinine, all right, your creatinine is within normal levels. So that creatinine of 2.5 is elevated. Yes, it's high. So you always want to go ahead and look at that before you start your vancomycin. You don't want to be a case where you already have a damaged kidney, and then you're going to give a medication that is going to cause some toxicity or further damage to that existing kidney that is damaged. All right, so always look at your lab values and have an idea. Know what the medication is going to be doing for the patient, and know what the side effects are going to be. And then from there, you'll be able to answer it. All right. So vancomycin is nephrotoxic, and a creatinine of 2.5 indicates impaired kidney function. So at this time, you will withhold the medication. You let the provider know, and then from there, they can use something that is alternative. All right, for that patient, if the patient definitely needs to get that antibiotic. All right, but you don't want to go ahead and run the risk of giving the patient a medication and the kidneys are already damaged. All right. Which diet is most appropriate for a client with hypertension? Is it high sodium, high fat? A. B. Low sodium or the DASH diet? C. The high protein, high fat diet? Or D. Regular diet with no restrictions? So you have a patient that is hypertensive. Which of the diet is appropriate for this patient? Is it the high sodium, high fat, low sodium, DASH diet, high protein, high fat, or regular diet with no restrictions? So we have B, low sodium. Okay, so low sodium DASH diet. And what's the DASH diet? We hear the talk about the DASH diet. What is considered to be a part of the DASH diet? So holy fowl, okay. All right, so basically making sure that you get the foods from the, the different food groups, making sure that you're eating your vegetables, your fruits, your whole grains, including your fat-free or low-fat dairy products, fish, poultry, beans, nuts. So basically make sure that they're eating anything that is low in sugar, anything that is low in, sodium, things like that, all right? So the low sodium DASH diet is the most appropriate. All right. High protein, high fat. Nothing is wrong with a high protein diet, but when you think about the high fat, you don't want that because you're thinking about your cholesterol level. All right. Regular diet with no restrictions. No, this patient is hypertensive. Probably they go home and just start eating a bunch of chips. You understand? You don't want that because you want their blood pressure to be controlled. High sodium, high fat, that is going to be a total no-no. All right. You're sending that patient to ICU or to the grave when you do that. So your low sodium, your DASH diet, it helps with lowering your blood pressure, and that is what you're going to recommend to your patient. And almost all the patients, we tend to tell them, you make sure you're eating properly. You're eating according to the DASH, diet. All right. Hello, Val. Welcome. All right. Let's go ahead and try to get the live up to, let's say, 5,000. I'm not that needy. Let me just kind of, wet my mouth a little. Yeah, let's try to get the live up to 5,000. And then from there, Island Breezy, welcome. I saw your message earlier. Yeah, so a lot of times you might not need to fast before your labs, depending on what you're doing. Unless you're doing like, anything with your diabetes or your cholesterol level. But for majority of the tests, you don't necessarily always have to fast for your test. All right. But I hope the results came back good. All right. And this is just a, what do you call it now? A sweetener? Yeah, a little sweetener in the water. Nothing wrong with that. Not true. Yeah, man, nothing wrong with it. Anyways, let's get cracking. All right. Let's get cracking. So which lab value indicates immediate intervention in a client with chronic kidney disease? So you have a patient with CKD, chronic kidney disease, and, you're browsing through the labs and you notice A, potassium of 6.2 milliequivalent per liters. B, sodium of 140. C, calcium of 8.9. D, hemoglobin of 12 grams per deciliters. Which of these requires immediate intervention? All right. What are we doing on fire? So which lab values requires immediate intervention in a client with chronic kidney disease? So Val says sodium. Do we have anybody else with anything else? Salt. Okay. Okay. All right. So, Millicent, hi. How are you doing? Read over the up. So the answers: A, potassium 6.2, B, sodium 140, C, calcium 8.9, or hemoglobin 12. So which lab value requires immediate intervention in a client with chronic kidney disease? So Carousel says A. Olifier says A. Okay, good. So definitely, why you thinking A, or why you says A? All right. Holy Fire, why did you say okay, arrhythmias? Definitely. So if you see a potassium of 6.2, even if a patient doesn't have chronic kidney disease, or if you don't know the history and you see that the potassium is just too high, always go ahead and, you know, alert the provider and start doing the different things that you need to do in terms of with this patient. So if the potassium is 6.2, you know, just go ahead and start jump on getting either your lab values. Try to repeat the sample, get an EKG, you know, get the patient connected to the cardiac monitor to make sure that, you know, there is no arrhythmias, there's no effects with the potassium being so high with this patient. All right, so always go ahead and do that. Your sodium of 140 is pretty normal, calcium is normal, hemoglobin is normal. All right, potassium can damage your kidneys, definitely. All right, so the effects of your damaged kidneys as well, you understand, results in the high potassium. All right, so you definitely want to do that. It is a life-threatening issue, so you definitely want to go ahead and address that, even if it's a case where the potassium is not potassium, but the sample is hemolyzed. You know, definitely go ahead, repeat, and see what the numbers are to make sure that this patient is not at risk for arrhythmias. All right, so definitely do that. What if the hemoglobin was 7? What if, you know, the question had read the potassium is 6.2, the hemoglobin is 7, calcium 8.9, sodium of 140? Would you still stick with your potassium, or would you go with the hemoglobin of 7 or say 6? So if the question, you know, had read hemoglobin of 6, the potassium is still at 6. You know, would you keep your potassium as your priority? Yes, definitely, definitely. All right, because, you know, it is life-threatening. Yes, the hemoglobin is low and you're probably not getting blood to different, you know, parts of the body. But you definitely want to be a case where you address your potassium, your arrhythmias, your risk for arrhythmias. And then from there, you can always go ahead and start a patient on the blood transfusion and everything. All right. The nurse is caring for a client with chest pain. Which action takes priority? All right. So which action takes priority? You have a patient that is having chest pain. Is it you administering nitroglycerin, which is A? B, place the client on oxygen. C, obtain an EKG. Or D, call the provider. So you have a patient with chest pain. Which action takes priority? A, administer nitroglycerin. B, place the client on oxygen. C, obtain an EKG, or D, call the provider. Okay, so Carousel says C, EKG, C. Okay, all right. So what about, you know, you're having this patient with chest pain, you're running out to get the EKG machine, but the patient is still having chest pain. And what is happening with the chest pain? When you're thinking about, you know, a patient having chest pain, you're thinking about what? So Rim says A, okay, which is administer nitroglycerin. Just think about what is happening when you have a patient that has chest pain. If you're having the pain, just think about if there is a clot. If there's a clot there, what is happening? Behind that little clot, you're having ischemia taking place because you're not having blood flow, oxygen flow to that area. So you're going to have ischemia taking place. So if you think about the pathophysiology behind chest pain, then you'll be able to choose the best answer. Because you obtaining an EKG, going to get an EKG, the patient is still there having that chest pain. You want to make sure that, you know, you're getting oxygen to that location to prevent worsening in the ischemia, in terms of the ischemia. So always go ahead and start with the simplest thing. Get your oxygen on and then you get your EKG. All right. Always remember assessment, breathing, circulation, airway breathing, circulation. all right, are priority. So you assess the patient, you realize that this is going on, the chest pain is there, you want to make sure you're perfusing your patient. All right, so get your oxygen on, and then from there, you can always go ahead, get your EKG and all right? So the correct answer is B. Oxygen is priority in suspected cardiac ischemia. So always use your ABCs in answering the question. And think about the pathophysiology. Look at the answers. Yes, you're going to be given your nitroglycerin if it is ordered, and depending on the type of, when you look at the EKG. But once it is ordered, you definitely go ahead and give it. But the first thing you want to do is put your patient on the oxygen to help with perfusing that area that is at risk for ischemia. Then you get your EKG. You can always call your provider. You get your order, and then you do your nitroglycerin. How often will you give your nitroglycerin if you're going to be giving that nitroglycerin? So the doctor writes the order for the nitroglycerin times 10 tablets. How many times are you going to be giving this medication? What's the max dose, the max amount of time you can actually give this medication? 1 tablet every 5 minutes, maximum of 3. Nice, nice. So you realize that the patient is having the chest pain and the patient's blood pressure is 85/60. 85/50, but the patient is having chest pain and the patient is like, nurse, I'm dying, and the patient is sweating. What would you do? You have the nitroglycerin, you're going to be giving that patient a medication. What are you going to be doing? So the patient's blood pressure is 85, 90, 60s. The patient is sweating. The patient is having the chest pain, and you have your nitroglycerin on hand. What are you going to be doing at that time? Are you going to give your nitroglycerin, hold your nitroglycerin? What are you going to be doing? Time is money. The heart is, important. What are you going to be doing for this patient? All right, so you give it. Okay, all right, you're going to give it. So, but before you give it, you must do certain things. Make sure you have your IV in place, all right? Make sure you have your 2 large bore IVs in place. Make sure you have some fluids in place to pump up that blood pressure. So whenever you give that medication, at least, the blood pressure is going to respond. But at the same time, you have fluids to counter the effects of the hypotension. So you want to address the hypotension before you go ahead and give your nitroglycerin. Because you don't want to be a case where you give the nitroglycerin, it's a vasodilator, and then the blood pressure is already low, and you go ahead and just open up the vessels like this, and then tank the patient's blood pressure. Now you have more problems dealing with. All right, so make sure you have your fluids going. Make sure you have your 2 IVs going, your fluids going, and then from there, you can make that decision. Give the little fluids, give the fluids, see if it is, improving the patient's blood pressure, and then you can always go ahead and start your patient on the nitro. All right, you might not give all of the 3 nitroglycerin because you don't want to bottom out the patient's, blood pressure. But at least you will try with that, see if they have any improvement. So, for example, the blood pressure was normal and you go ahead and you do your nitroglycerin. The patient still having pain. What is the next, best thing for you to go ahead and give this patient? So the blood pressure is normal. You gave the 3 nitroglycerin. The patient is still having a lot of pain. What else can you go ahead and give the patient based on what you know about chest pain? Once it is ordered, what medication are you anticipating? All right, so you remember your Mona, right? Your morphine. So always think about your morphine as secondary. So you give the 3 nitroglycerin and it doesn't help. You can always go ahead and ask the doctor for some morphine to help with that. All right. And you know about the oxygen, your nitroglycerin, and your aspirin. All right. All right. Any question? All right, let's keep going. The nurse is caring for a client with cirrhosis and ascites. Which order should the nurse question? So you have a patient that has cirrhosis of the liver and ascites. Which order should the nurse question? Is it A, a low sodium diet, B, administering spironolactone, C, encourage high protein diet, or D, restricting fluids? All right, so you have a patient with cirrhosis and ascites. Which order should the nurse question? Is it A, the low sodium diet, B, administering spironolactone, C, encourage high protein diet, or D, restricting fluids? So Alicia Muir, welcome. She says D. Okay, restricting fluids. Do we have anybody else with another answer? Holy File say D. Val says protein. So definitely the protein. You want to encourage high protein diet. All right. You don't want to encourage high protein diet because you're thinking about the ammonia level. All right. So you don't want to do that. So in severe cirrhosis and hepatic encephalopathy, protein should be restricted to decrease your ammonia buildup. All right. So you're always going to go ahead, do your low sodium diet. You administer your spironolactone to help with getting rid of some of that fluid. Restricting fluids, you're going to restrict your fluids definitely. But the encouraging high protein diet, that's the one that you're going to question, because the protein along with the ammonia built up is something that you're going to be concerned about with your patients in cirrhosis. All right. So definitely question that one. All right. A nurse is caring for a burn patient. Which fluid would be used for initial resuscitation? Is it the normal saline? Is it the dextrose the dextrose water? Is it the lactated ringers or the albumin? So you have a patient that is a burn patient. The patient comes in. You haven't seen the order as yet. What is the fluid that you're going to be getting for this patient? So Marvel says 3 lactated ringers. Do we have anybody else with any other answer? So you have a patient, a burn patient that comes in, and the patient is to be started on fluids. Which of the medications are you going to be rushing to get? So lactated ringers, definitely. Regular saline, no. So you're going to go with the lactated ringers, all right? That is usually the preferred fluids for your patients with burns in the first 24 hours. All right. At what point do you normally use albumin? When do you use albumin? Oh, this thing here. When do you normally use albumin on your patients? Thank you for the follow. Regular. Okay, so regular fluids because they did not get any order for the patient. But even so, the regular normal saline, you have to get orders for that one as well. So all of the fluids, whatever it is that you're giving the patient, even if it is Tylenol, paracetamol, you have to get an order for it. You know, a lot of times you might just hang it and it just seem like, but you have to get an order for it. You have to get an order for oxygen, pulse oximeter testing. You have to get orders for those. All right, so cirrhosis, yes, you definitely can use it in cirrhosis. You needed to expand the fluid, definitely. Fluid overload. Okay, definitely. So you definitely use your you can always use your albumin. So for example, you have that patient and you realize that the patient is having the fluid shift. The albumin level is very low and all. You can always go ahead and get your albumin to help with that. Sometimes their blood pressure is just so low. You can always go ahead and administer your albumin to help with getting their blood pressure back as well. So when you're in an accident and the EMT come for you, they start IV, so they get an order for that. So definitely they have standing orders that they're working with. Yeah, so they're not just working, but they have orders that they're working with. All right, so they have to get that. After resuscitating with the isotonic fluids and the patient is still hypotonic. Yes, definitely hypovolemic. You can always go ahead and start your albumin there as well. But yes, your EMS, your EMTs, they have, orders from the providers that they're working with. All right. There's always like a medical officer, a doctor that they're working with. So they're not just there, taking up cardizem or epinephrine or any form of drug and just giving it to patients just like that without any orders. Somebody has to sign off on it. All right, Renorta? Yeah. All right. All right. Let's go on to a pediatrics question. So a newborn's APGAR score at 1 minute is heart rate of 140, a strong cry, active motion, pink body, blue extremities, grimace to suction. What is the score? Probably you won't know this one, but so what's the score? So based on the APGAR score, so APGAR score is a test that they use whenever you have, you have a baby that is being born. They have different things. Carousel says 8. Okay, you're close. You're close. Okay, 8. Val says 8. Only 5. It's actually 9 though. It's actually 9. So with the APGAR, let me pull it up because I haven't done the APGAR, let me just go through it. So with the APGAR score, the APGAR actually means the APGAR actually is a mnemonic, all right? And then each of them is assigned like, points. So A is for appearance. So let me pull this up. So usually you look at that, or the nurses will look at that whenever they have a patient that has just delivered and their baby is out. So Olifile says yes. So you definitely want to look at A, which is appearance, the skin color. So you give different points, and each letter can score up to 2 points. All right. So you always want to get the highest point for that patient. All right. So appearance. So skin color, 0 points is if they are blue or pale. For 1 point it is pink body, blue extremities. 2 points is if they're pink. P is for pulse. You want to check to see if it is absent. 0 pulse. 1 point if it is below 100, or 2 points if it is over 100. So for the pulse, for the babies, newborns, if it is below 100, is that good or bad? What's the normal heart rate you're looking for a neonate? So you just have a baby, a neonate that is being born. Is 60 to 100 the normal heart rate for that child or neonate? Or would you be worried? You think it's 140? 140 is good. Would you be worried if the heart rate is 100 or 60? Greater than 100, Dorian Perks. Okay. Yeah, so you're not looking for the heart rate to be, the same as an adult. All right, you're looking for it to be higher. So in the 140s, 160s, 150s, usually when they are delivered, you're looking for their heart rate to be like that. All right. So if that patient has a heart rate below 100, then that would be 1 point. So you want the heart rate to be over 100 beats per minute for the newborn. G is grimace, all right? Whether or not it's floppy, 0. 1 point if it's minimal response to stimulation. Or 2, prompt response to stimulation. And A is activity, the muscle tone. 0 points if it is absence. 1 point if it is flexed arms and legs. And 2 points if they're active. And R, respiration, absent, 0 point. 1 point slow and irregular. And 2 points if it is a vigorous cry. So usually when the babies come out and them start squeal, you touch them and them just start make a lot of noise, definitely them APGAR score is like, you can evaluate the patient from there and you can just give them their full points on their APGAR. All right. But then when you look and you realize the baby is blue, the baby not crying, then you're going to have to sit down and calculate all of that APGAR score. All right, on that child. All right. Good night, good night, good night. Thank you for tuning in. All right. So the answer is actually 9, which is B. So heart rate is 2, which is heart rate 140, cry is 2, motion 2, color 1, reflex 2, and it's total to 9 there. All right. So A postpartum client with preeclampsia has seizure. All right. What is the nurse's priority? Is it A, administer magnesium sulfate, B, call for help and protect the airway, C, document the seizure activity, or D, provide emotional support for the family? So you have a postpartum client with preeclampsia that has seizure. What is the nurse's priority? Is it to administer magnesium sulfate, call for help and protect the airway, document the seizure activity, or provide emotional support to the family? So this lady, she was diagnosed with preeclampsia. She just had her baby. All right. And she's now having seizures in front of you. What is it that you're going to be doing for this patient? So I see BA document. So B is call for help and protect the airway. A, administer magnesium sulfate. And D is provide emotional support. Magnesium. All right. So a postpartum client with preeclampsia as seizure. So the patient is has already delivered the baby, and now the patient is having seizure. What is it that you're going to be doing? Are you going to administer the magnesium sulfate? So B, call for help and protect the airway, because remember, this patient is seizing. Remember, you're using the answers that they have available, all right? So you call for help and protect the airway, definitely. Document the seizure activity is going to be important afterwards. Provide emotional support for the family is always going to be one. Administer magnesium sulfate. Remember, so usually in eclampsia, whenever the patient is having, the seizure. So whenever the patient is having the seizure, you normally go ahead and you start them on the magnesium, help with dilating and everything like that, relaxation and all. So you always start the magnesium at that time. But this patient is postpartum. And so you can always go ahead and start other medication that is not like, magnesium. But magnesium is pretty safe during pregnancy, and it helps with, as I say, the tone. It helps with the relaxation, dilation, and everything during that time, and the seizure. All right. But postpartum, you can always go ahead and start your other medications. I don't know if they'll probably start the magnesium. I don't know. All right. But you call for help and protect the airway, and everything else goes with it. All right. So if the patient is pregnant, the patient has been diagnosed with preeclampsia, and now the patient is having active seizure. The patient hasn't delivered as yet. Is that patient still in preeclampsia, or what phase is that patient in? What stage of the eclampsia or the preeclampsia is this patient in? Eclampsia, yes. So now the patient is full-blown eclampsia, because the preeclampsia is when they would be having, they're pregnant, they're having the protein in the urine, the swelling in the lower extremities, the blood pressure is high. So they are heading in that direction. So until they start having the seizure, they are still actually in preeclampsia, but when they start having the seizure, they're now in eclampsia. All right. Welcome, Just a Girl. All right. I think I had some select. Okay. All right. So a pregnant woman at 36 weeks presents with painless vaginal bleeding. What condition is suspected? All right, so you have a pregnant woman at 36 weeks, and she's having painless vaginal bleeding. Which condition is suspected? And one thing you have to remember is you have painless vaginal bleeding and you have painful vaginal bleeding. So you have to know which one is painless and which one is painful. All right. So is it placental abruption? Is it placenta previa, preterm labor, or uterine rupture? Okay, I see a few persons put it down there. Placenta previa. Yes. And one way I always remember it is when I think about abruption, just think about something abruptly happening. You rip it. If you're thinking about the placenta ripping off, it's going to be painful. You understand? It's going to be painful. when you think about the previa, that is the one that is painless. All right, so the placenta previous, and you have the abruptio placenta. Yes, so those are the two types, painful and painless. And if you can connect or think about abruption being sudden impact, you have that ripping, you'll have pain. And then the other one is the painless one. All right. Hold on 1 minute. All right. Yes. So always just think about that. All right. So placenta previa typically presents with painless, bright red vaginal bleeding in late pregnancy. All right. Preterm labor sometimes will, you definitely will be having pain with that one. All right. Uterine rupture again. Just think about rupture. A lot of time rupture just always something painful. So you always want to think about that as well. All right. So 36 weeks, painless, vaginal bleeding. What condition is suspected? It is going to be placenta previa. Would you do a vaginal exam? So for example, this patient comes in. Would you do a vaginal exam on this patient to look where, what's happening down there?
What does daddy gonna come?
Nope. Yes. No. You don't want to go down there and poke the bear or do anything. All right. You don't want to be doing any of that. So you'd call, depending on your team, call your team, get this patient prep, and then from there they will go ahead and do what they're supposed to be doing. All right, but you don't want to be going down there doing any poking, doing any examination or anything that is going to cause further bleeding or trauma to the placenta there. All right. All right. All right, so the nurse is preparing to insert an NG tube. Which action is most important? Lubricate the tip with water-based gel. Tilt the head of the bed 45 to 90 degrees. Ask the client to hold his or her breath, or insert the NG tube quickly while the client exhales. So the nurse is preparing to insert an NG tube. Which action is most important? Lubricating the tube with water-based gel, A. B. Tilt the head of the bed 45 degrees to 90 degrees. C. Ask the client to hold their breath. Or D. Insert the NG tube quickly while the client exhales. B. Okay, so B, tilt the head of the bed 45 to 90 degrees. Why do we tilt it? Why are you tilting the bed? Why do we reposition the patient or expand the lungs? Okay. Anything else? Prevent aspiration, definitely. Can you imagine you're tickling somebody's, throat? And what is going to be happening? You're going to be gagging. You're going to want to feel like, you're throwing up. So just imagine you have a patient lying down, or you're lying down and somebody trying to put a tube in your nose. You understand? And then you are choking. You feel as though you're choking. There's a risk for aspiration. So you don't want anything to be going in your lungs. So definitely get the patient in an upright position. And then from there, at least, you'll prevent the risk for aspiration for that patient. So B is the actual answer. Tilt the head of the bed 45 to 90 degrees when you're doing this NG tube. Lubricating the tip with water-based gel, that's fine, all right, because it's going to help with getting that tube down a little bit easier. Because can you imagine you're inserting a tube down in somebody's nasal passage? Some persons tend to have a lot of, secretion there, so that will help. and it's already moist. The nasal passage is moist, but just imagine you're inserting a tip or NG tube in somebody's nasal passage and it dry. You understand? It's not going to be a nice feeling. You understand? Even sometimes when you're doing it, you can actually feel like you're having some resistance, especially those patients who haven't been eating, drinking. You can actually feel it in there, when you're pushing it down. It just feels like you're rubbing against a tree. Yeah, you don't want that. So definitely lubricate as much as you possibly can to get that tube down and less painful for the patient. All right, ask the client to hold their breath. Do you ask them to hold their breath? I tend to ask them to hold it for a second, because once I do that, the mind, you can easily just push it down. And I think a lot of times they tolerate it better. Insert quickly while the client exhale. I really don't know if it's when they're exhaling, but me just know that I tell them, hold the breath for a few seconds and I just quickly push it down. All right. So definitely all of those will help. No. Okay. Okay, definitely. But the semifolus position reduces aspiration risk during insertion. Yes, you can also tell them to swallow. Some persons, I see them giving the water, they're drinking the fluids while they are inserting the NG tube. I don't normally do that because can you imagine probably if you ask them to be drinking water and some of them will drink a lot of fluids, they will drink a lot of fluids and then when the NG tube go down, you're not getting anything back from the NG tube. You understand? Depending on what you're putting it in for. So I usually don't encourage the water, but to each his own. I guess you have to tell them to just sip, sip, sip. But some persons will be there drinking the entire thing. And by the time you look, you haven't gotten the NG tube in. So I tell them to still just pretend as though they're sucking on something and then from there. All right. All right. The client was, yes. Yes, I usually don't let them do that. All right. A client is prescribed gentamicin. Which finding is most concerning for you? Is it A, tinnitus, B, headache, C, nausea, or D, fatigue? So you have a client that is prescribed gentamicin. Which finding is most concerning? A, tinnitus, B, headache, C, nausea, or D, fatigue? Okay, so Lady Mal says A, Carousel says A, definitely. And why are you concerned about tinnitus? Every day people have ringing in the ears. So why are you concerned about tinnitus? What is so special about the ringing in the ear? Why not, nausea, ototoxicity, definitely. So there are certain medications they definitely need to know, what they cause. You understand? In terms of the side effects or what organ they specifically, affect. So that way, whenever you're educating your patient, you can tell them that if you're hearing in your ears, don't take the medication again, or let your provider know. Things like those. So mycin. So your mycin, a lot of your mycins tend to have toxicity, like the kidneys as well as your ear. All right, so you tend to have nephrotoxicity and your ototoxicity. So your vancomycin tends to cause problems with your kidneys. So definitely look out for your kidney damage. You look at your creatinine, and then your mycin, your gentamicin tend to have ototoxicity. And a lot of times you might find this on the question, on the exam. You might find one or two of these things about toxicity, ototoxicity, or the nephrotoxicity with the drugs. All right. So tinnitus indicates ototoxicity, a severe adverse effect of aminoglycosides. All right. Headache, nausea, fatigue, those are pretty common, side effects, but it depends on what they're, they put in the question. You'll choose the one that is most appropriate at that time. All right. A client with acute pancreatitis reports severe abdominal pain radiating to the back. Which intervention is priority? So you have a patient that is having acute pancreatitis and the patient is having severe abdominal pain radiating to the back. Which intervention is priority? Is it place the client in a supine position, keep the client NPO, encourage oral fluids, or administer high-fat diet? So you have a client that has acute pancreatitis who is reporting severe abdominal pain radiating to the back. Which intervention is priority? Is it A, place the client in a supine position, B, keep the patient NPO, encourage oral fluids, or administer high-fat diet? So Carousel says B. Okay, Just a Girl says B. And why do we say B? B, keep the patient NPO. Why are you keeping this patient NPO? Why not give the patient more food to eat? Why you want to starve the patient? Okay, maybe need emergency surgery. Okay. So you want to go ahead and make sure you're resting that pancreas. All right, you want to rest that pancreas. So pancreatitis, when you have a patient with pancreatitis, you know, they keep them NPO to rest the pancreas. All right, placing the client in supine position for comfort, that would be good as well. Encourage oral fluids. You don't want to encourage your oral fluids at that time. As I say, if you have the pancreatitis going on, you want to keep, you know, the patient free from, you know, eating anything or drinking anything at that time. Give them IV fluids and then from there. All right, administer high-fat diet. Would you give them high-fat diet at that time? You have a patient that is having pancreatitis. Would you be giving them, you know, foods that are high in fat? No, definitely not. All right, no. All right. So for example, what is something that you're concerned about? So for example, would you be concerned about, you know, the patient's glucose? Is that something that you would be keeping an eye on with a patient with pancreatitis? Would you be thinking that their glucose level is going to be high or low? Yes. Okay. Are you looking for it to be high or on the lower side? And why you're concerned about it? Do watch for possible rupture as well. High. Okay. High. Why high though? Why are you concerned about it being high? Because the pancreas is not functioning properly to release insulin. So, okay. Yeah, so it's going to be low. So you're looking out for those patients and making sure they're not going hypoglycemic. All right, because their pancreas is not functioning. So you want to make sure that you're checking their glucose regularly to make sure they're not going hypoglycemic, because pancreas is not able to release, as Doriana says here, the insulin. All right, so keep an eye on your glucose for those patients, and especially with the fact that they're not eating as well. You want to make sure you have your dextrose water close by, you know, or at least know where it's located, because you're not feeding this patient and then the pancreas is giving problem. So you're running the risk of hypoglycemia for that patient. All right. So it's 8:17. Let me try to do one more question. And then from there. All right. So a client in labor receives an epidural. All right. So you have a patient in labor that is getting epidural. Which finding requires priority intervention for this patient? Is it A, blood pressure of 80/40, B, a fetal heart rate of 140, C, maternal shivering, or D, pain score of 5 out of 10? So you have a mother in labor and is getting epidural. Which finding requires priority intervention? Carousels A. Okay. All right. So the blood pressure of 80/40, fetal heart rate 140, maternal shivering, pain, you know, score of 5 out of 10. And why are you concerned about A, the blood pressure of 80/40? With a patient that is getting epidural. Low blood pressure. Okay, blood pressure is low. Yes. Okay. So all the time you have people with low blood pressure. So what if this patient has low blood pressure? Why are you concerned about it? Does it cause respiratory depression? So hypertension is a complication, may suppress the system more. What about the blood flow to the baby? What about, getting that placenta perfused properly? Are you concerned about that? If you don't have, so yes, hypertension is a complication of it. But you're thinking also along the line where you're having, decreased blood flow to that placenta, to the baby. So you want to make sure you're keeping an eye on that and address it immediately. All right. Fetal heart rate 140, that is good. Mother shivering. Yes, we tend to shiver a little bit. It's gonna happen. All right. And pain score 5 out of 10. She's in labor, so expect that. All right. So the hypertension is a major complication of epidural and can cause decreased placental perfusion. So you want to keep an eye on the blood pressure to make sure that, mother is doing well. And once you correct, they always tell you that once you correct, so always resuscitate the mother. So once you address the blood pressure, once you address the heart rate, baby is fine. All right. It makes sense to try to, resuscitate the baby and the mother is unstable. All right. So always go ahead and make sure the blood pressure is fine. Once the blood pressure is fine, everything else is good. All right, because you're gonna have adequate flow of blood to the placenta. Baby's gonna be doing well, and from there. So always resuscitate. So if you have a pregnant patient that comes in, and that patient was involved in a motor vehicle accident, they always say, go ahead and resuscitate the mother. You're resuscitating the mother. Once you're saving the mother, most of the time you save the baby as well. All right, and then from there, that's. Thank you guys. Any questions, any concerns, anything you want to add? I say I'm only doing 1 hour today. I think I'm doing 1.5 hours. So I'll go until 8:30. Thank you for the follow, everyone. Nadia, thank you for following. Shells, Dorian. Shells is blessed. Welcome. How are you? All right. And remember to go ahead. If you miss out on the full live here, you can always go over to YouTube at ThinkNursing. All my live sessions are over there. You can also check me out at 5:30 in the morning for my Peloton class. I'm doing my cycling classes, so definitely check that out as well on both page. Definitely. Not a problem. Dorian. Not a problem. All right. So definitely follow over there. And as usual, if you're a nurse and you want to share 1 and 2 things about, your background or a day in the life, I'm trying to get my podcast up and running. So I'm open to having persons come on the show and just share. It's more like a sit down. Oh, one more thing. Let me just tell you, seeing that I have 45 persons here on the live. So I have this gentleman I met last night. Well, husband and wife. Let me see if I have the book here. So they are Forever Blessed. I don't know if they're on the live, but they have a 4-year-old, that they dedicate this book to. So definitely go ahead and follow them and, try to support them as much as possible. They did a book in memory of their daughter. Where is it? Okay. All right. So go ahead and support them. They haven't been getting much sales, so definitely try and see if you can support them. They're Forever Blessed. I don't know if they're on the live. I don't know. I think my internet is a little bit slow. But the book is Geraldine Bailey. I don't remember the first part. Sorry. Okay. So it costs $10. All right, $10 for the Kindle version. The hardcover is $40, and the paperback is $18. Depending on where in the world you are, you can get it delivered as early as Thursday. All right. So this is a little girl. She had rhabdosarcoma, so the parents decided to go ahead and write a book. All right. In honor of her. So that's her. So the book says The Journey of a Warrior Princess, Geraldine Bailey. All right. So this is by Rashida Thomas Bailey, her mom. And then at the back, they did write, Geraldine was the earth angel God loaned to us. Since her diagnosis at the age of 4 years old in 2015, she has touched many lives with her bubbly personality, strong faith in God, and her beautiful outlook on life. The rigors of hospital life and her overall medical journey tested our faith at its core. Our warrior princess demonstrated grace throughout it all, leaving nuggets of strength, love, and truth for our learning. Experience Geraldine's prayers and encouraging words that are bolded for emphasis. You will be pulled into her world through her enthusiasm and adoration for her Heavenly Father. All right, so you can go ahead and check out their page. I think they are Forever Blessed. I think it's like Forever Blessed, their page is. All right, so they're trying to get their book sold, just to, as a reminder for Geraldine. So definitely go ahead and support them as much as you possibly can. All right, I will go ahead and upload it to my page here so you can always see it and try to order it for your little ones, or just to put it on your bookshelf, or to say that you got something from, TikTok or Amazon, or yeah. But anyways, it was nice having you guys here. Thank you for tuning in, and I will see you guys on Thursday again. We can do a little bit longer in terms of the live on Thursday because I'm not working on Friday. Thank you for the what's that? Go Popular, Luminous. All right, and then from there, but join me at 7 o'clock in the evenings where we kind of do a little chit chat. So if you're new here and you're not familiar with me, I'm Stacy, by the way. Yes, Stacy Ann. And I'm an international nurse. I transitioned here from Jamaica. So if you want to hear anything regarding my journey, or if you want to ask questions, I'm very transparent in terms of how I migrated. So I normally come on live at 7 o'clock and you can always ask a ton of questions if you want to, use that pathway. Not saying you want to do brain drain in your country, but we know a lot of people need opportunities. So I got opportunity and I'm here to just share how I did it. So definitely go ahead and, pop onto one of the live and ask the questions. And I'm also a nurse practitioner. So I talk about, things in the outside world as well. So definitely. And I'm trying to get a foundation going as well because I want to give back. I want to do a lot of community service. So that's also in the making. So if you have a lot of money and you want to donate it somewhere, you have a lot of places, that definitely would benefit from things like, a little wheelchair, a bed, a little clothing, food, things like that. So hit me up, the Lord will bless you as always. And then from there, but that's what I am working towards. All right. But until then, I'm out. I will see you guys tomorrow or the next day. All right. But I'll be up at 5:30 for my spin class. All right. Until then, I'm out. All right. Good night. Good night. Good night. And thank you so much for tuning in. I don't know who is on here at TT. Hi. Welcome. All right. Remember to go ahead and subscribe to my page. Yeah, remember to go ahead and subscribe to my YouTube page. It's ThinkNursing. All right. Yes, ThinkNursing. All right, then. Enjoy your evening now, people. Bye.